Hoda Hassab. Dr. Hoda is a professor of pediatric hematology oncology at Skandaria University, and she's a well-known national and international figure and a principal investigator in lots of trials, phase 2 and 3 multinational trials, وحاصلة على جائزة الدولة التقديرية. دكتورة هدى هتكلمنا عن الأبلاستيك أنيميا. Is it an immune disease? تفضلي دكتورة هدى.
Thank you very much, Professor Mona, for the kind introduction. حصل على جائزة الجامعة، لسه جائزة الدولة. First of all, I would like to congratulations Professor Azza for this excellent scientific meeting and for this foundation that takes care of the rare diseases. I would like to thank Novartis for inviting me to share with you my talk today about aplastic anemia. Is it an immune disease? As you all know, aplastic anemia is a life-threatening bone marrow failure disorder. It is characterized by pancytopenia and hypocellular bone marrow and associated with high mortality rate if left untreated. And there is no single test that provide a diagnosis of aplastic anemia. The diagnosis is a process of excluding other bone marrow failure conditions. And this is the famous figure showing the overlap between the different bone marrow failure syndromes. It can be classified into inherited aplastic anemia in 15 to 20% of cases, or acquired, most of cases are acquired in more than 70% of cases, or secondary or iatrogenic in 10 to 15% of cases. In the inherited bone marrow failure syndromes, they carry the genes that are important for hematopoiesis, have mutations that lead to progressive failure of the hematopoietic stem cells to keep normal circulating blood cells. While there is direct damage to the bone marrow and its microenvironment by infections, chemicals, chemotherapy, radiation, and drugs. However, the acquired aplastic anemia like paroxysmal nocturnal hemoglobinuria, large granular lymphocytic leukemia, myelodysplastic syndrome, they all have immune-mediated mechanism and they lead to aplastic anemia, and all these syndromes may progress to acute myeloid leukemia. So, aplastic anemia, is it an immune disease? The proposed pathophysiology of aplastic anemia is immune dysregulation leading to autologous attack by T cytotoxic lymphocytes against the hematopoietic stem cells through activation of the tumor necrosis factor interferon gamma that activate their receptors, as well as the FAS receptor that binds to FAS ligand, and they induce apoptosis of the hematopoietic stem cells, as well as the toxic nitric oxide gas production that is toxic to other cells, inducing apoptosis of the hematopoietic stem cells and severe aplastic anemia. The cytogenetic abnormalities in acquired aplastic anemia may coexist, and hematopoietic stem cell depletion may cause the recruitment of a genetically defective clone. Like in PNH, the classic PNH can evolve into marrow failure. All patients with PNH show evidence of hematopoietic deficiency. And myelodysplastic syndrome, there is aneuploidy and usually monosomy 7 and trisomy 8. And as you all know, monosomy 7 is associated with the progress to refractory cytopenia or AML. Another classification of aplastic anemia according to severity, the severe aplastic anemia, where bone marrow cellularity equals to 25% and peripheral blood criteria, absolute neutrophil count less than 500, platelet count less than 20,000, and reticulocyte count less than 20,000. Very severe aplastic anemia is classified if the absolute neutrophil count is less than 200. While the non-severe or moderate aplastic anemia that does not meet the criteria of severe and very severe. Although it may occur at all age groups, it has a biphasic age distribution with peaks at two ages from 10 to 25 years and more than 60 years, and there is no significant difference in incidence between both sexes. In children, majority are diagnosed below the age of 16 years. More than 25% of children have the aplastic anemia of genetic origin, and they are lucky enough that 90% disease-free survival after allogeneic stem cell transplantation. The clinical presentation differ according to in different bone marrow failure syndromes, but in acquired aplastic anemia, it can present abruptly with the onset within few days or over weeks to months, and the common presenting symptoms are bleeding, purpura, ecchymosis, and mucous membrane bleeding. And visual disturbance due to retinal hemorrhage are common in these patients. And this figure shows the normal hematopoietic stem cells in the normal bone marrow and the replacement by fatty tissue in the aplastic anemia cases. So how do we treat the aplastic anemia? The treatment strategy depends on the severity and the degree of cytopenia. In non-severe aplastic anemia, where there is no variable course and rarely life-threatening, we just observe, and therapy may not be needed, observe and monitor, and supportive care or cyclosporin if needed. In severe aplastic anemia or worsening of the course of the non-severe aplastic anemia, with worsening pancytopenia, life-threatening therapy is needed to restore physiological levels of blood components, supportive care, and hematopoietic stem cells if the age is below 40 years, and having HLA-matched sibling donor. If not, we start the immune suppressive therapy that lead to hematological recovery in 60 to 70% of patients. If there is failure or relapse after immune suppressive therapy, we proceed to unrelated and alternative hematopoietic stem cell transplantation or TPO receptor agonists. The hematopoietic stem cell transplantation is potentially curative and restores hematopoiesis. It is the treatment of choice for children and young adults aged below 40 years who have an HLA-matched sibling donor. And it is associated with a lower risk of relapse or developing cytogenetic disorders. The main sources include mobilized peripheral blood and bone marrow, and still the cord blood use in aplastic anemia, and its outcomes need to be defined. And the survival of patients from having HLA identical sibling transplant is much better than the unrelated donor. How about immune suppressive? It is the first line treatment if the patient doesn't have a donor, and hematopoietic response to immune suppressive ranges from 50 to 80%. The standard regimen contains high dose ATG and cyclosporin. Approximately 1/3 of the patients fail to respond to immune suppressive or relapse. The development of cytogenetic abnormalities and associated clinical disorders usually occur within 2 to 4 years from starting the immune suppressive therapy. And improvement of survival here is good, but it's lower than that, the survival after hematopoietic stem cell transplantation. So still, aplastic anemia patients have unmet needs in the treatment. What are the unmet needs? The hematopoietic stem cell transplantation and immune suppressive are current options for treatment, but they have their limitations. Fewer than 30% of patients have an HLA-matched sibling donor, and it is associated also with potentially life-threatening complications like graft versus host disease. Patients may relapse or become refractory to immune suppressive. A second course with rapid ATG and cyclosporin A may be associated with variable response rates, but this is often inferior to responses seen in the relapsed setting. Long-term supportive care may be needed and associated with significant burden, like repeated transfusion may lead to iron overload and damage to the organs. Alloimmunization may limit transfusion efficacy after repeated use, and disease progression to cytogenetic disorders such as myelodysplastic syndrome and leukemia occurs at a rate of 10 to 15%. So what is the role of the thrombopoietin in hematopoiesis? Thrombopoietin acts through thrombopoietin receptor. It is essential for normal hematopoiesis. TPO receptors are present on primitive cells, which means TPO is also involved in early hematopoiesis. It may act at multiple levels to stimulate hematopoiesis. It stimulates the common megakaryocyte progenitor and the megakaryocyte erythroid progenitor. So this means that it is stimulating multi-lineage and not a single lineage in hematopoiesis. And as Professor Azza elegantly presented, the thrombopoietin reacts through reaction with the thrombopoietin receptor, and it interacts with the transmembrane domain. So this is another different binding site than the normal thrombopoietin. And L-thrombopag is FDA approved for use in severe aplastic anemia in 2014 and by EMA in 2015. In severe aplastic anemia, what is the dose differs, and take care because here it differs than the ITP. In ITP, as Professor Azza said, you cannot exceed the dose of 75 milligram per day. But here in aplastic anemia, we start by the dose if the platelet count less than 50,000, following less than 2 weeks of L-thrombopag treatment, we increase the daily dose by 50 milligram to a maximum of 150 milligram per day. For patients taking 25 milligram, we increase the dose by 25 milligram first to become 50 milligram per day, and then start to increase the dose by 50 milligram. The platelet count between 200 and 400,000, we decrease the daily dose by 50 milligram and wait 2 weeks to assess the effects of this and any subsequent dose adjustments. Reaching the platelet count more than 400, we have to stop L-thrombopag at least for 1 week and repeat the platelet count. If the platelet count decreases again less than 150,000, reinitiate therapy at a daily dose reduced by 50 milligram. If the platelet count is stable more than 400,000 after 2 weeks of therapy at lowest dose of L-thrombopag, we can discontinue and stop the drug. The lowest possible dose of L-thrombopag should be used to initiate and maintain a hematological response. Serum thrombopoietin levels in aplastic anemia, unlike the ITP, are elevated in patients with aplastic anemia because of the different binding sites, like we said. So L-thrombopag has an additive effect to the normal thrombopoietin. And platelet count and white blood cell count in vivo and expansion of cells in vivo with thrombopoietin or L-thrombopag are increased because of its function in early hematopoiesis. So L-thrombopag stimulates stem cells, may increase probability of recovery, and stem cell number may be a limiting factor for responsiveness to immune suppressive therapy. Blood counts may reflect stem cell reserve and have been proposed as predictors of response to immune suppressive. A lack of response may be due to the limited number of hematopoietic stem cells. Quickly, they started to do the clinical trials of L-thrombopag in refractory severe aplastic anemia. The primary objective to see the safety and efficacy in refractory aplastic anemia. They gave 43 patients aged more than 12 years and refractory immune suppressive therapy for 6 months, 50 milligram daily, and they did dose escalation every 2 weeks to 150 milligram. The hematological response was observed at 3 to 4 months. Non-responders were off study, and responders were followed monthly on drug in the extension study. These are the characteristics. L-Trombopag was efficacious in 40% of patients with refractory. 40% were responder, and 26 were non-responders. And they found that it can produce multilineage responses over time, and patients became non-transfusion dependent as regards the red cells and platelet transfusion. And there is normalization of bone marrow cellularity after 8 months of treatment with L-Trombopag. And platelets more than 50,000, hemoglobin more than 10 grams, and neutrophils more than 1,000 in more than 8 weeks after during treatment. You have to decrease the dose by 50%, and counts remain above limit for 8 weeks. You have to stop the drug. When we stop the drug, will the patient relapse? No, they found that patients kept the normal cellularity of the bone marrow 39 months and 6 months of the drug. So it was safe, the safety profile. Some serious when to stop the drug if you have adverse event. If the patient have suspected cataract, abdominal discomfort, or acute hepatitis B, you have to stop the drug. And there are more clinical trials ongoing for studying L-Trombopag in aplastic anemia. They used it as first-line treatment with immune suppressive therapy. There is overall response and complete response higher compared to historical immune suppressive alone. There was clonal evolution, but the frequency was also comparable to the use of immune suppressive alone. Some patients, 2 patients had cytogenetic abnormality of unclear significance, and 5 patients had loss of chromosome 7. And patients are keeping the cellularity for either 3 or 6 months with the use of immune suppressive in addition to L-Trombopag. And to summarize, the take-home message is aplastic anemia is characterized by hematopoietic failure and multilineage cytopenia. Hematopoietic stem cell transplantation and immune suppressive therapy are standard of care. L-Trombopag may stimulate hematopoiesis by non-competitive activation of TPO receptor. Clinical studies have shown that it is effective treatment for refractory aplastic anemia, and it is safe and effective treatment option in patients with severe aplastic anemia initially, alone in mild cases, or in severe cases together with immune suppressive therapy. Thank you.
شكرا جزيلا الدكتورة هدى.